Hello, good morning or good afternoon, depending on where you are in Canada, and welcome to the second in our webinar series on creating Canada's rare disease drug strategy. I'm really delighted to be joined with our panelist presenters, and our panelists are going to respond to those presentations here. I will introduce them a little bit shortly as we get into the webinar. But for the moment, then I'm going to move into hopefully being able to move into the actual start of the webinar. Okay, so just to introduce, this webinar series is being sponsored by the Canadian Organization for Rare Disorders, and it is our countdown to Canada's rare disease drug strategy. It is our fall series. It is the second in our series. Last week we talked about the rationale for a rare disease regulatory framework and an orphan drug policy. This week, we're going to start looking at some of the challenges we have in terms of accessing therapies under our current regimen and why it is that we need to have a rare disease drug strategy. I always like to start with this to give us a little of a context. It is what I call the rare opportunity of a lifetime. I won't go to this in deep detail, but I think those of you who have been paying attention will recognize that a number of things have been moving on the federal and provincial front. I've got here expected October the 20th, the Patent Medicines Price Review Board, new guidelines on pricing of medicines in Canada, which also has a huge impact on rare disease drugs. And I am, for those of you who may not have heard, in fact, those final guidelines came down this morning. We've been consulting with them, with the PMPRB and other stakeholders over the past year and a half, and they have finally come out to be implemented in January. Those of you who have known our position have recognize that we have expressed a great deal of concern on behalf of rare disease patients in terms of what these guidelines provide in terms of restrictions on drug pricing, to the point where it is in fact very difficult for drug companies to indicate that they will be able to come to Canada. And sadly, this final set of guidelines does not move substantially from the first draft that we saw, where we really protested against the rules that they're putting in and also the process that they were putting in, including the application of very strong economic factors to restricting the price. So this came down today. We'll be issuing some brief statements around it, but I will tell you that this speaks even more strongly to why this series is so important. We recognize that as a rare disease community, we really need to take the initiative to move forward to trying to advance access for rare disease drugs, because nobody else is doing it for us. And that aside, then, to say that one of the things, and a couple of the things that have driven us here is what you see here. September 2020, those of you paying attention, we had a speech from the throne where the government recommitted to rare diseases, and especially committed to a rare disease strategy. So this is important for us because it's not just speaking to drugs, but it speaks to the fact that we need to have a program, we need to have a framework in Canada that would allow us to be able to support rare diseases, including diagnosis, clinical care, supportive programs that would allow us to be able to not only bring in drug therapies, but to make sure that they're used appropriately to their optimal benefit. So we were very pleased to see the rare disease strategy referenced in the throne speech. Again, the big impetus for us here was in the February 2019, a budget from the federal government that committed $1 billion to setting up a national rare disease drug strategy with a target date of 2022, $1 billion over 2 years to set up the program, which we hope will include some of the infrastructure. But again, for us, it was the opportunity then to move forward in helping to propose what would be in this drug strategy. What does it need to look like in order to work for us? 2019, I won't, those of you who took part, remembering that Dr. Hoskins came out with a Pharmacare for All report, and in there also recognized the need to have a national expert panel to work with patients and clinicians, specifying that rare disease drugs should be funded, but it would also be needed to be dealt with outside of a regular Pharmacare stream. And then in November 2018, we had the Expensive Drugs for Rare Diseases Working Group from the provinces and territories, who recommended as well a supplemental process, recognizing again the challenges of being able to provide timely and appropriate access to rare disease drugs. We need to have a parallel process that would allow us to make sure these drugs were appropriately reviewed and appropriately accessed in a managed program perspective. And then, November 2018 was also when Health Canada produced their designated regulatory approach to drugs for rare diseases and orphan drugs. Those of you who are taking part in some of the other work that we've done or in our patient training program will have an opportunity to actually hear more about, exactly what is included in that regulatory approach, how it helps to expedite access to the rare disease drugs. So that was the impetus. As we said 2 weeks ago, we had our first webinar. This is our second webinar looking at therapies that can prevent and reduce the risk in terms of relapsing or symptoms in rare diseases. And we will have 3 more in this series before we lead up to a conference that will be taking place in December, hopefully bringing some of these issues together and launching then a nationwide consultation on setting up a rare disease drug strategy. And really, we're hoping that everybody will continue to take a role and take part with us. So these are the consultation dates, December 2020. We've yet to put out the exact dates. We will do a national consultation. We will be doing provincial forums from January to April. We'll hopefully have a consolidated feedback in May. We will be doing more consultations from June to August on what we see as a consolidation, hopefully to have a collaborative document October 21st, 21. And by the end of the year, we would hope to have a document that would allow us to be ready to go at a time when, in theory, that $1 billion should be in play for us to be able to implement. As I said, this is something that we're driving forth from the perspective of the rare disease community, including our patients and our clinicians and many other stakeholders as well. So we are really, really delighted. The webinar series is going to be a little bit different than some of the ones we've had before. We're choosing to focus on key therapies, key issues that we feel need to be addressed and fall outside of our traditional regulatory and access framework. So what we're going to hear today is 3 case studies on the access to preventive and risk reduction therapies. What are the key issues? What are the benefits of therapies that can prevent or reduce the risk of serious symptomology in rare diseases? What are the challenges in approval of these therapies? And what you'll hear is, in fact, that one of these therapies has gone through the process and has actually been full stopped at this point, even though there is, in fact, huge need and benefit from it. What are these in going to access through the public and private plans, and why are these therapies especially relevant in a time of a pandemic? And this is something that we're very concerned about, because in many cases, we're seeing that certainly preventive therapies that can keep people out of hospital or keeping them from becoming symptomatic, are even more important when we see the strain in terms of our other healthcare resources. So what we're going to do is have 3 very, unfortunately, somewhat brief presentations, but we're really so grateful to our experts who are going to be talking to us about it from 3 different diseases and the therapies. But I think you'll understand the complementarity of these presentations, the benefits of these therapies, and why, in fact, we're very concerned that we are able to make them available, but very concerned they're not available. We're going to invite 3 of the persons living with these rare blood disorders to talk about their experience in terms of access to these therapies, and then hopefully have a chance to do a bit of a Q&A. So given the fact that we're in a very tight time frame, I'm going to introduce all 3 of our experts and have them present one after the other. And I'm so very grateful for them for taking the time out of, I know it's very busy schedules, not only in terms of their usual care, but obviously the additions that they've got with regard to COVID. So the first speaker up will be Dr. Katerina Pavinsky from St. Mike's Hospital, who's going to be talking to us about HTTP acquired. Now I'm full stop on the word, but she'll give it to us better. And then Dr. Kevin Cole from the University Health Network, who's going to speak again in terms of thalassemia, and David Page from the Canadian Hemophilia Society, who's going to be talking about it from the point of view of hemophilia. So without any further ado, I'm going to turn it over to Dr. Pavinsky. Dr. Pavinsky, I will just be managing the slides, so just tell me when you want to advance, okay? So over to you.
Hello, everyone. So I will talk to you about caplacizumab for treatment of immune or acquired thrombotic thrombocytopenic purpura, TTP. It's a mouthful. No, I know why you stumbled. It's okay. Let's go over to the next slide.
Oops, sorry, went backwards.
So this condition presents with hemolytic anemia, so that's the breakdown of red blood cells, low platelet count, and even though it presents with low platelet count, it is associated with increased risk of blood clots, and these blood clots preferentially form in small blood vessels of the heart, brain, and kidney. Other organs could also be involved, but the heart, brain, and kidney are disproportionately involved. We have no Canadian data, other than we know that about 200 patients get treated with plasma exchange for this type of condition. We know from European and American data that the annual incidence is somewhere about 2 cases per million, which makes this an ultra rare disease. It mainly affects adults, and it mainly affects women, and it mainly affects women in their reproductive years. Next slide. TTP is caused by severe deficiency of ADAMTS13, which is a very, very important blood protein. So what ADAMTS13 does, it prevents another blood protein from becoming too big and causing damage to the platelets, to the red cells, and ultimately resulting in thrombosis. And you can have ADAMTS13 deficiency because you were born that way. Usually that's hereditary form. And at some point, I'm sure I'll be coming back and talking to you about that one as well, because there are emerging therapies for that as well. But today I'm going to be concentrating on the immune form, which is the most predominant form in the adult patient population, and that's deficiency in ADAMTS13 as a result of an autoantibody, IgG autoantibody. Next slide. So I like pictures, but I'm going to make it super simple. There is von Willebrand factor protein and hangs off the blood vessels. It hangs into the circulation, and it unfolds the faster the blood flows. And ADAMTS13 comes around and chops it up from this protein becoming a problem. Now, in the absence of ADAMTS13, what's going to happen is a mess over here. So the VWF, or von Willebrand factor protein, will interact with platelets, consume the platelets, and form a clot that will then go on and obstruct small blood vessels, causing organ damage. And ultimately, if untreated, this condition is fatal. Next slide. There are 3 pillars of treatment. So the first one is to replace ADAMTS13. The second one is to get rid of the antibody. And the third one is to prevent VWF and platelets from coming together and causing blood clots. So the standard of care in Canada currently is plasma exchange, and that's to give the ADAMTS13 back. The second step is to suppress immune system, and that's usually accomplished with high-dose steroids. In most countries, rituximab is also used upfront. That is not the case in Canada because it's neither licensed nor reimbursed for this indication. So we usually use it later on in the disease course for refractory relapse disease. And we currently do not have access to the third strategy, which is the prevention of interaction between VWF and platelets. And it is really important to point out that the platelet count is what determines when plasma exchange is going to be stopped and when steroids will be tapered. Next slide. Very briefly, acute complications I mentioned involve heart, brain, and kidney. So about 50% of patients will have evidence of damage on presentation. And if you are going to diagnose the condition quickly and transfer the patient to appropriate facility, treat them with everything you've got, which is your plasmapheresis and immunosuppression. As it stands right now, mortality is anywhere between 10 and 20%, depending on the facility you are treating and obviously comorbid conditions of the patients. If it is untreated, essentially this condition is uniformly and very rapidly fatal. Next slide. Now, in the past, people thought TTP is all about acute complications, and now we realize that some of that organ damage that occurs up front can lead to complications down the road. Specifically, what we know about is persistent cognitive abnormalities and permanent neurological deficits. The reason this is super important is because a lot of patients who are affected by these conditions are young patients in the prime of their lives, busy mothers who are juggling the family and their jobs. And the lifetime risk of relapse for this condition is about 40%. And currently, none of the strategies that we've got address this long-term complications. Next slide. So here enters caplacizumab. This is a nanobody. It's a part of an antibody. And what it does, it specifically comes between VWF and platelets, preventing them from coming together and forming these blood clots in the small microvasculature. It is not a treatment for ADAMTS13 deficiency, which is the causative agent of TTP. It is intended to prevent complications of TTP, preventing the blood clots, which ultimately lead to organ damage and death. So this drug is given as soon as diagnosis is made. That's how the studies were designed that were done. There were 2 randomized controlled trials in this area during the time of plasma exchange, and then you can continue after cessation of plasmapheresis. So I said 2 trials have been done, published in New England Journal of Medicine. More than 200 patients were involved in these trials. And the major findings were that caplacizumab significantly reduced time to platelet count normalization. And you would say, oh, why did they decide to look at platelets and not something more significant? Because it is a rare disease, because the complications are not common, and it is very difficult to show a difference. And this is why the platelet count was chosen. Moreover, platelet count is what we currently use to decide on stopping the current therapies that are available. So CAPLA showed that there was reduced time to platelet count normalization, and the side effect profile was very favorable. Next slide. In a number of analyses that followed, it became clear that it can also reduce mortality and refractory disease. It can cause, it can prevent exacerbation of the disease. So for example, once you stop plasma exchange, but you're still ADAMTS13 deficient, so your immunosuppression hasn't quite kicked in and nipped the disease in the bud, the platelet count will drop again, organ damage will ensue again. What usually happens to these patients, they get readmitted to the hospital, get placed back on plasma exchange. So caplacizumab prevents that from happening. Very importantly, from TTP patients, you'll hear what they hate the most is being on plasma exchange, being in hospital, being in the intensive care unit. All of these have been shown to be reduced with this drug. Next slide. And I believe this is my last slide, which, so this drug underwent review by both INES in Quebec and CADTH for the rest of Canada. And the recommendation was against reimbursement of this medication. There were a number of things that were cited as reasons. I just put down on the screen what CADTH said, only because INES is in French and I'm not fluent in French and I'm not going to embarrass myself trying to interpret it, but the gist is very, very similar. First and foremost, that it was platelet count used, not death, not hospitalization. That follow-up was not long enough, even though this drug, first and foremost, is used to treat acute manifestations of TTP. Whether it will down the road improve these downstream long-term complications remains to be shown, and that has not been studied yet. That's not what the drug was designed to do. And finally, when we argued that at least allow us to use this drug in some patients who are refractory or have very significant organ damage, the response was disease is quite heterogeneous. We cannot identify a group of patients who most likely to benefit. Therefore, we do not recommend reimbursement. And I want to conclude this with a throwback to the history of TTP. So a very important randomized controlled trial that was performed in Canada. The biggest contribution of Canadians to treatment of TTP was the trial conducted by Gail Rock in the 90s that compared plasma infusion versus plasma exchange and ultimately showed that platelet count gets better in patients who receive plasma exchange. Remember, platelet count as a primary outcome. That trial led to the most fundamental seismic shift in the treatment of TTP that ultimately resulted in mortality going from 90% to less than 20%. So I think it's a bit ironic to think about it now, many years down the road, and having faced these types of criticism that we have received. Thank you. I hope I didn't go over time.
I don't know, but that was brilliant. It was not only very clear, I think your last statement there really brings it all the way back home. It also does show we say over and over, we have the most amazing specialists and experts in Canada. We need to make sure that they're also meaningfully able to help advance the research and access to therapy. So that was brilliantly done. Thank you so very much, Dr. Pavensky. So I'm going to switch immediately over then to Dr. Kevin Cole, who's going to talk to us about different disease or some and the treatment here. Dr. Cole, over to you.
Thank you, Doreen, and thank you to Court for inviting me to present. Today, I will talk about patients living with thalassemia in Canada, and then later on, you're going to hear from patients on this panel who can talk about it, their own lives living with this disease. And I'm also going to talk about how luspatercept can potentially change the course of the disease. Next, please. My conflict of interest disclosures. I'll leave it up for, you don't want to leave it up for people's edification for at least 10 seconds? That's okay.
It's okay, it'll be in the deck.
All right. So caring for patients of transfusion-dependent thalassemias, patients in Canada, we estimate that in Canada, there are approximately 600 patients with thalassemia, and that translates into a prevalence of 1.6 in 100,000. But the data accuracy is really limited by a comprehensive national registry. And in the largest center alone, we have 170 transfusion-dependent thalassemia patients, of which 13 new patients are enrolled into the clinic each year, mainly because of immigration. And as you know, many patients are from Middle East and from South Asia and East Asia and Europe as well. And these are the main areas where thalassemia is prevalent. Luckily, in Canada, we have 9 comprehensive care centers, which is showcased at the bottom left here in the map. And we also have the Canadian Hemoglobinopathy Association, which oversees the care of these patients. And we have a comprehensive guideline that we have recently published. In conjunction with the Thalassemia Foundation Canada. Next, please. So what is thalassemia? Thalassemia essentially is a mutation in hemoglobin, and hemoglobin is used for carrying oxygen to all parts of the body. And when and hemoglobin is made of 2 components, the alpha globin and the beta globin. You need 2 alpha globin and 2 beta globin and pair them up in order for them to dance. Now, when there is either a missing alpha or missing beta, or that there is a reduction in the production, or that there's some sort of qualitative change to either the alpha and beta, you get thalassemia. So if you talk about beta thalassemia, it is a lack of or reduction in beta globin, and conversely, there is a relative increase in alpha globin. Now, if you talk about alpha thalassemia, is the reverse. You have a reduction in alpha globin and an increase in beta globin. Any of these discrepancies, any of these differences, the excess alpha or the excess beta is going to translate into disease. And because these excess globin can aggregate, can gel together within the developing red cells, causing damages to the red cells, and eventually these red cells will be destroyed either in the bone marrow, or that as soon as they come out of the bone marrow into the circulation, they'll be destroyed very quickly. And when this destruction occurs, it results in anemia. Now, thalassemias exist in a huge spectrum, going from all the way from normal, right, where you have a perfect balance between alpha and beta, to very severe where you have no beta at all and you only have alpha, or vice versa. And then you have everybody in between. Next, please. And then you can see that sometimes when there is also an excess of a particular, let's say alpha or beta globin, you can create more severe phenotype. Next, please. And so patients with either thalassemia major, which is on the right-hand side of this slide here, or those with intermediate, which is the next one beside the major, are usually transfusion dependent as a result. Next, please. And because and why do we transfuse these patients? Well, first of all, many patients have very severe anemia to a point where they can't even survive in childhood. You know, if you don't transfuse them, they die within 4 months to 4 years. And then in many patients, even if they do survive the childhood, the metabolic demand during puberty is going to outstrip the supply of blood such that they need to enter transfusion. And then there are those later in life who develop complications from the thalassemia itself. For example, extramedullary hematopoiesis. These are masses that can push along the spine, causing paralysis, or bony deformities, or iron overload, even in the absence of transfusion, and leg ulcers and so forth, and bony fractures that will lead to the need for transfusion. The problem with transfusion is that you're creating a whole set of new problems, which is iron overload. And then the iron overload then requires chelation, which itself has a lot of side effects. That's essentially telling you as a patient that, well, you have a deadly disease, but I can treat you with a treatment that is going to give you 100% side effects. Everybody gets side effect universally. And I can treat you with that side effect with a whole bunch of medications that is going to cause more side effects because those medications are inherently toxic. And these are the iron chelators. Well, as a patient, are you going to accept such a treatment if, say, you have an acquired disease? Of course, you would want to search for an alternative. You don't want to be stuck with this treatment forever because it's simply unsustainable. And I'm sure that the panelist afterwards is going to tell you how unsustainable this approach is going to be. Next, please. So the journey of transfusion-dependent thalassemic patients in Canada is such that, as I said before, the first wave of people requiring transfusions is between 4 months and 4 years. And then later on, as puberty hits, that's the second wave. We can try splenectomy, but really splenectomy only is able to reduce the transfusion amount that is required, but doesn't eliminate transfusion. Bone marrow transplant is limited by the donor availability and toxicity, such that less than 1% of patients go through bone marrow transplant. So our patients live with this triad of commitment that I call with transfusion, constant transfusions every 3 to 4 weeks of transfusions. Plus, they have to have labs and imaging, right, to monitor for the iron overload, to monitor the hemoglobin. And then, of course, they have the drugs that they need to take that are potentially toxic to them. Next. Luspatercept is what we call an erythroid maturation agent that neutralizes a type of protein called TGF-beta superfamily. And by inhibiting that, you can inhibit a pathway that essentially kills the red cells that are developing within the marrow. So you can imagine that the TGF-beta superfamily is a checkpoint. It's like a police saying that, well, no go, because this developing red cell is defective. I'm going to weed you out. They are sort of the quality control guys. Well, if you kick the quality control guys out, then these cells, even though they are defective, they will be removed into the circulation and serve their purpose, even though the purpose may be very limited in terms of lifespan. So that's the idea. Next, please. So BELIEVE trial is a phase 3 study where adult patients with thalassemia who are getting around 6 to 20 units of red cells in the past half a year are randomized to, in a 2-to-1 fashion, to either the drug luspatercept or to placebo. And then after 48 weeks observing on these patients, they can then go into the drug up to 5 years. Next, please. This study met the primary endpoint where 21% of patients who were treated with luspatercept achieved to have more than 33% reduction from the baseline transfusion burden compared to only 4% in placebo. All the key secondary endpoints are also met. Next, please. There's also a change in iron parameters. As I said before, with transfusions, you get iron overload, and this is where a lot of the damages, a lot of complications comes from. So this study was also able to show that over a long-term, over 2-year period, 96 weeks, that you can improve iron overload in patients who received the drug, who responded to the drug. And you can see that those who responded to the drug had a greater reduction in the transfusion, in the iron reduction in iron overload compared to those who didn't respond according to the primary endpoint. And you can see also here that patients who are on placebo actually had an increase in liver iron overload. Next, please. And in terms of toxicity, those that are more than, say, the placebo, who are more frequent than placebo, includes anemia, increase in liver iron concentration, which is somewhat ironic because this data I'm presenting to you is actually from the 1-year mark, not the 2-year mark. So initially there was an increase in liver iron concentration, but then subsequently there was a reduction in liver iron concentration. Most importantly is that there were an increased number of clots in patients who were receiving luspatercept compared to placebo, but mainly this is due to the fact that all these patients had splenectomy in the past. Next, please. So just to give you a couple of examples in how patients have benefited from this drug, AB is a 34-year-old female who was a beta thalassemia major, transfusion dependent since age 1 and has splenectomy age 3, but failed to reduce the transfusion burden. And patient was on this drug called deferoxamine, which is a subcutaneous medication. Essentially, you jab yourself with a needle 5 to 7 nights a week, for 8 to 10 hours a night. Between ages 9 and 20. So imagine a mom having to insert this needle into a little girl or a little boy, every night for their life. It's really heart-wrenching to see and to think about. And then subsequently, they switched on to the oral medication called deferoxamine, but even then, the patient was still dependent on transfusion with 3 units every 4 weeks. Unfortunately, because the deferoxamine really caused a lot of diarrhea, so the patient actually had a lot of side effects from the medication, and there's reduction in adherence, and they got a lot of iron overload in both the heart and in the liver, and so had to go back onto deferoxamine, now the IV version, for 3 years. And then subsequently was switched to combination therapy. Next. The patient then got onto the BELIEVE trial now 3 years ago. The transfusion burden was reduced by 1 unit to 1 unit every 3 weeks, and the liver iron concentration completely normalized. And currently, the patient is only on a single drug to treat the iron overload instead of having 2. Next. Patient CD is a 25-year-old gentleman, again, transfusion-dependent thalassemia, started transfusion at age 3, again was on the deferoxamine, the subcutaneous medication, until 14 years old, and then switched to deferoxamine. Unfortunately, not too adherent to deferoxamine either because of the side effects. He was on 4 units of red cells every 4 weeks, joined the BELIEVE trials 3 years ago, with the transfusion burden again reduced to 2 units every 3 weeks, and the liver iron concentration has now largely went from moderate to mild iron overload. Next. So the conclusion is that the management of thalassemia syndrome traditionally has relied on chronic transfusions and chelation, and we can see that this strategy was completely unsustainable, leading to patients developing complications from the disease, even though they were transfused and chelated. Luspatercept is the first disease-modifying agent in thalassemia ever since the discovery by Cooley's, back in 1902. And luspatercept has shown a statistically improvement in both the primary endpoint of transfusion reduction as well as a reduction in liver iron concentration. And the drug was well tolerated in this patient population. Thank you.
Thank you very much. And don't you love it when physicians can present so clearly? So much appreciated. We're going to switch then directly into David Page, who I know presents very clearly. David, over to you.
Thanks, Johanna, and thanks to Cord for the invitation. So Johanna's asked me to talk about a new innovation in hemophilia care, which is called Hemlibra, or emicizumab, for the treatment of hemophilia A. It's specifically about how this innovation can reduce the non-drug costs related to the condition, as well as what are the barriers to its introduction into Canada. Next slide. A few very quick words and pictures about what is hemophilia. So hemophilia, there are a lot of myths about it, but what it really is bleeding into elbows, knees, and ankles, soft tissues, and muscles, either following trauma or for no apparent cause. And when the bleeding is into vital organs, it's fatal. Without treatment, crippling is the result within, usually by the age of 10 or 15. Next slide. The current treatment is replacement of the missing factor VIII, that's the protein that's missing in hemophilia, by IV infusion. And as you can see in the photo, This is often by the patient himself, even young boys, or by the caregiver at home, 2 to 3 infusions per week. This is efficacious in 90% of the severe cases. We've got about 1,000 cases of severe hemophilia in Canada, but actually 30% develop factor VIII antibodies, and a third of those, so 10%, have antibodies which can't be removed. And when there are antibodies to factor VIII, treatment is very difficult, not very efficacious, extremely expensive, and children don't do very well. There's now, with people without inhibitors, or a normal life expectancy, but patients continue to have bleeds up to 1 to 12 per year into joints, and joint damage still occurs. Next slide. With young children, venous access is very difficult, and so central venous access devices are often used in babies and young children. That's a very high burden of care in terms of proper antiseptic technique, and there remains a risk of infection and thrombosis. These sometimes have to be removed and replaced. Next slide. So this is a typical week in a person with hemophilia A without inhibitors. 3 infusions per week, Monday, Wednesday, Friday morning. It has a very short half-life. The level goes up to could be between 50 and 100% of normal immediately after the infusion, but then falls down very quickly to a level about 1% of normal factor VIII, which protects to a certain extent, but certainly not perfectly. Next slide. That brings us to the innovative treatment, which is called emicizumab or Hemlibra, and this is a monoclonal antibody that mimics factor VIII in the coagulation cascade. And unlike factor VIII, it's not intravenous; it's injected subcutaneously once a week, and it attains a steady state hemostasis rather than the peaks and troughs that you see with factor VIII. You get a steady level, about 10 to 15% of normal, which is enough to prevent most bleeding in most patients. So it's very efficacious, and only a very tiny percentage of people develop anti-drug antibodies. So it's something that doesn't cause the frequent antibodies that we see with factor VIII. Patients have fewer bleeds, according to the research, an average of 1 per year. The real endpoint is joint damage. It's probably too early to say whether there's less joint damage. We only have a few years of treatment around the world, but certainly we could predict that this will result in much less joint damage. Next slide. So the pros and the cons of the current therapy versus the innovation. Factor VIII has pros. It's a human molecule, or almost. It's recombinant. A very long history, safe, efficacious if given very frequently. It gives high peak levels, which is nice if you're doing sports. You can inject at them just before the sports. And it's a monotherapy. There's only one of them. You don't have to have 2 different kinds of treatments. It has some severe disadvantages. It's IV infusion. Adherence is very difficult. I think very few people actually adhere to their doctor's prescription of 3 times a week without fail. Joint damage still results. We have a high inhibitor rate, 30% of children, and 10% with a recurring inhibitor. And the protection is very low at the trough level of 1%. Hemlibra, on the other hand, is steady state, no troughs, improved efficacy. It's subcutaneous, which is a huge advance. Adherence is much easier. Certainly patients prefer it. The 7,000 patients who have switched around the world will not switch back. And there's extensive research. The clinical trials included 400 people, which is quite a bit. It's a very big clinical trial for hemophilia. The cons, well, we still have only short experience. It's only 4 or 5 years on the market around the world. You don't get the peak levels that you have with factor VIII. You still might need factor VIII in a surgical situation. And we don't really know right now in Canada. It may be more costly. That we'll have to see. Next slide. So what's really interesting about this is a paper from Australia, which shows the non-treatment direct savings and the indirect savings from a switch to Hemlibra. And this is something I think which is often ignored in some of the HTA assessments. It's not an easy thing to do, but they have documented And you see the huge list of savings in relation to other medical interventions, as well as the savings to the family in terms of productivity and absenteeism. Next slide. So, but there are barriers to access, and so HTA times 3. So we've had several HTAs with Hemlibra. In 2019, an HTA by Cadith for CBS approved it for inhibitor patients, a clear benefit medically and huge cost savings, but was very negative in terms of for non-inhibitor patients. They did not consult with the patient or physician associations. They compared apples and oranges in terms of pricing. In other words, they compared the list price for the innovation to the negotiated price for the comparator, and they wildly exaggerated numbers of patients who might take up the therapy. So I think they didn't do their homework. And so they had garbage in terms of the inputs and garbage out in terms of the conclusion. Next slide. A second HTA, a full HTA in this case by Ines in Quebec, came to the conclusion that there was a lack of evidence of non-inferiority. In other words, it wasn't as good as factor VIII, and recommended not to be funded. I think there was huge scientific errors in there. They accepted low annual bleed rates for the comparator products in very small studies, but they rejected evidence of lower annual bleed rates with Hemlibra, despite much larger studies. They only consulted a single physician with known bias, and they certainly heard the patient perspective in their report, but they discounted it when it came time to actually make a decision. They discounted the burden of treatment and the patient experience of lack of efficacy with the current product. Next slide. So our experience with HTAs, and it's somewhat limited to this and a few other products, is that Canadian HTA bodies don't properly consult the patient community and discount their experience in the decision. They don't properly consult the medical community and rely on single voices. They don't adjust to the reality of rare diseases and the small numbers in research, and they don't take into account real-world treatment costs. They don't take into account the non-drug related savings of innovative therapies. Next slide. And that's it. Thank you very much.
Okay, so what I'm going to do then is, oh, good, we got people back already. Thank you very much, David, and thank you to Dr. Pavensky, and thank you, Dr. Cole, for brilliant lead-ins. I wish we had a huge more time to actually just discuss it, but I think before we open it up for more discussion, I'm going to switch over to the patients, and these are patients who've had experience with the therapies you're talking about. I'm going to actually start with hopefully being able to bring in Yulan, who is not on camera. She's hunkered down somewhere in the high school boardroom or something. Yulan, can you hear us?
Yeah, can you hear me?
We can indeed. Well, why don't you introduce yourself and your experience with your condition with ATTP and your experience with regard to access to CAPLA.
Okay, thank you. Thanks for having me. My name is Yulan Walters, and I'm a patient with TTP. I was diagnosed August 14th, the year 2008. I've had 4 relapses since then, and my last relapse was in June of 2018. I ended up in the ICU at St. Mike's, and I have to say Dr. Preventive, Megan, and Patty, they pretty much saved my life with the drug CAPLA. Dr. Preventive had to advocate to get the drug in to Canada so I could live another day, and I'm pretty much living another day for the last, say, I'm in remission for the last 2 going on 3 years. So I have to say that I'm pretty much a guinea pig to this drug, and so far I'm holding my own. I haven't had any plasmapheresis, and I rarely do my blood work because I'm just really anxious about my platelets going down. So I would go every 2 weeks or every 3 weeks, and Dr. Preventive had to tell me to stretch it out. So now I feel a little bit more comfortable stretching it out. But now we're faced with COVID, and I have to be even extra careful that I don't contract that disease as well. So my hope is that this drug Capla will be accessible to patients like me with TTP in order to live a little bit longer, because if not, as the doctors were saying, it could be very fatal. And ending up in ICU 2018, I was almost there. So again, I have to thank Dr. Pravinsky for advocating and really championing to get this drug to save my life. And so that's my story. Thank you.
Thanks, Yulan. But I'm going to swivel over to Dr. Pravinsky before we go to the other patients, because I want you to maybe tell us how you actually got Capla, and if in fact you have a patient like Yulan today, given the fact that we've already got a no from Cardiff, what would be the experience of trying to get access to Capla for a patient?
So I didn't include my disclosure slides, but I will absolutely be sending them so they can become part of the deck. I was an investigator on the Hercules trial, which was the second trial of caplacizumab. There were a number of Canadian sites. St. Mike's happened to be the biggest one. We managed to recruit a number of patients into the trial, and we watched firsthand what a difference it made and how quickly it made a difference compared to standard of care therapy. And so the trial was over, and then we were waiting for results, and then results came out, and then the drug wasn't available. And since then, there were a few patients with whom I would have very much liked to use the drug, but it just wasn't available. And then we had Yulan, who came in with a very, very bad relapse, and despite massive escalation in therapy, was just not responding to anything. And at that point, I reached out to the company, who since then been bought by a larger company. It's, as always happens with rare diseases, I'm sure that happens everywhere, and asked them if they would consider giving me a drug on compassionate grounds because I had experience with it and because I was an investigator in the trial. It was a tremendous ordeal, and I cannot thank enough the pharmacists, my nurses, people moved heaven and earth to get it across the border. And anyways, long story short, she got it, and it wasn't too late. She responded quite quickly and was able to leave ICU and eventually leave the hospital. And so a lot of folks who have never witnessed this drug in action were actually appropriately blown away. Since then, we had, again, a big black hole of no accessibility to the drug because the company was being bought and there was no compassionate program. Currently, there is a compassionate program. So the drug was purchased by a larger company that committed to have a compassionate program. Since then, I have been able to use the drug, and because of all the difficulties, I try to use it in cases where it's either the organ damage is really severe or the patient is quite refractory. That's not how it was intended to be used. It was intended to be used upfront in all patients. So I don't know if it's right or wrong, but it's better than nothing. And I know that if you were to speak to other physicians across Canada, you may not have such a positive experience with trying to obtain it. So I've heard from my colleagues trying to get it and not being able to get it, having to go through a lot of red tape. So
thank you very much. And I think we can all appreciate the fact that we should not have a system that relies on the ability of the physician to have these kinds of connections and to have to move, as you say, heaven and earth to be able to save a patient. I'm going to switch then over to Uzma. And maybe Uzma, if you can tell us your experience and access to therapy and what you would see in terms of the future, because this is one that has not yet gone through the Catalyst review system.
So my name is Uzma. I am a beta thalassemia major patient in Toronto. I'm 36. I was diagnosed at 3. I started transfusions about that age. I had a splenectomy at 4, started desoxyamine at about 9 or 10. Obviously lots of complications. And then at one point I was on the sub-Q as well as the IV was not working. So I started on XJADE on a trial, and then on to JADE-NU. And I'm currently on the Believe study, which is really exciting for me. I went from going for transfusions every 3 to 4 weeks for 2 units to every 6 weeks for 3 units. So it's like a very big increase. So I've had a lot of positive results. I do have to be on blood thinner because of my splenectomy, so I am more susceptible to blood clots. It's been a good experience. I haven't really had any major side effects. I get swelling at the site, but that's just because I'm allergic to something. But other than that, like I think it's really important for rare diseases to have access to these types of drugs, because for me, to go from a situation where I'm getting 2 units of transfusion, 2 units of red blood cells every 4 weeks, 3 to 4 weeks, to 3 units every 6 weeks, that's a major shift, because that lowers my iron burden as well. It lowers just by virtue of the fact that I'm no longer getting as much red blood cells transfused. So for me, it's especially important because that decreases the amount of chelation that I have to do, which decreases toxicity in my liver, toxicity in my heart. And I think that because I'm still on a study, like I'm really lucky, like I still have like 4 to 5 years to be on this drug. But once the study's over, what happens, right? Like it's not going to be a drug that's going to be inexpensive. It's a subcutaneous injection that's given every 3 weeks. It has to be done either by a specialist nurse or at a specialist pharmacy. And that's definitely not something that's affordable for the average Canadian or average person in general. So I don't know what the answer is in terms of how we get this drug available to more people and to have access to it in a way that's effective as well as manageable. But I definitely think that it does need to be funded by a federal a body. I don't think that thousands of dollars out of pocket a month is sustainable. I think that being a transfusion dependent thalassemia patient, it's the therapies right now in terms of just like the JNU and transfusions and other iron chelators, they cause more problems than they solve sometimes, especially with patients that are non-compliant or with patients that have reactions or their side effects are severe. A drug like luspatercept can really lessen the burden
Thank you. Yeah,
of other therapies. Yeah.
Thanks a whole lot, Uzma. I think that was really amazing. And Dr. Cole, I mean, anything you want to add to it? I know you do see a number of patients. Are there some patients for which this is absolutely more, beneficial, essential than others? What is your experience now?
I think that there are many different factors that go into whether a patient will succeed on the medication or not. And really, if we examine all the patients who have been on the trial, it's really a continuum of response, meaning that some people do respond better than others, but everybody will gain some measure of response.
Okay, thanks a lot. Okay, and again, this is just coming up for Canada's review, but we are concerned. Leanne, I'm going to switch over to you, and maybe you can talk a bit about your experience, because I know it's, again, something quite different than the others.
Yeah, thanks for having me today. At birth, my son Jace was diagnosed with hemophilia, a rare bleeding disorder, as David had mentioned in his slides. At 14 months old, he developed an antibody called an inhibitor to the medication used to treat and prevent his bleeding episodes. Jace needed daily infusions to prevent bleeding, which was hard on his veins. So at 2 years old, he had an IVAD surgically implanted so we could administer his medication. Surgery for Jace meant a 7-day stay at the hospital to control the bleeding. Joint and muscle bleeds would occur often from Jace, from basic activities like running, playing on the monkey bars, or falling down at the park. Jace was around 5 years old when the bleeds began one after the other. Medication was no longer working to control the bleeds. We had to infuse up to 5 times a day. He had to rely on a wheelchair to get around at school. Participating at recess or gym class was not an option, which isolated him from his peers. He had bleed so frequently that we needed to leave his IVAD accessed for long periods of time, causing it to eventually need replacing, which meant more surgeries. He was 7 years old and we were running out of options. Long-term damage to his joints and all the bleeding episodes was a great concern. He was in and out of the hospital for months, missing several days of school. One day, Jace jumped off his bed, causing a right ankle bleed. He was hospitalized for 2 months in excruciating pain from the bleeding episode from the blood gathering in his joint. There were days he did not sleep and would scream from the pain. We knew a medication, imacizumab, was our best and only option, but it was not yet available in Canada. We rallied with the help of the CHS, Canadian Hemophilia Society, and after a few weeks, Health Canada and Roche granted Jace compassionate care use of imacizumab. 7 weeks after being in the hospital, he received his first dose of Emmy. The drug started working immediately. We were discharged from the hospital the next day. With a lot of physio appointments and hard work, Jace was running at recess and playing with his friends weeks later with a slight limp. Within 2 months, Jace had had a full recovery. Jace has been busy joining several school sports teams, going outside for recess and participating in gym class now. Our families had no interruptions from hemophilia's unpredictability. When traveling, we used to bring 3 suitcases full of medication and supplies, just for Jace. Now with Emmy, we travel with a small backpack Jace carries himself on his back. Emmy is given subcutaneously, so no more veins or IVAD needles needed. We administer his injections once a week in his arms or legs. The shot itself takes about 20 seconds. Surgeries have been a lot easier on Emmy as well. Jace had 2 teeth extracted. Before, he would have been in the hospital for 7 days. Instead, we gave Jace Emmy, he had the surgery, and we went home within an hour with no bleeding. He has not had one muscle or joint bleed since the day of his first imacizumab injection. This is over 2 years bleed-free. This also means no hospital stays for Jace. He actually misses the hospital. He said he misses the nurses. My perspective on hemophilia has changed significantly over the past 2 years. Hemophilia is now merely a small aspect of our lives. We're lucky to be where we are today, and if Jace was not granted compassionate care in 2018, our lives and Jace's life would be very different today. While Emmy is not a cure, it's a viable option, especially for hemophilia patients that are having troubles with other available products. Thanks.
Thank you so much. That's such a brilliant story. We're so really thrilled that he's doing well, and it's that night and day. David, maybe you can kind of just provide a bit of where the next steps are for this.
Yeah, so I can just add that since 2018, all patients with inhibitors have been granted access to imacizumab and have all switched with very similar results to Jace's. So that's great. It's been refused for the non-inhibitor population, and the company has reapplied, and we're right in the middle of that HTA. We're expecting a decision sometime early in 2021. Just point out that the entire developed world has already granted imacizumab access to severe patients, except New Zealand and Canada. We're the last 2. So I'm hoping for a positive result, but I'm not sure.
So thank you very much. We're just about at the top of the hour, so I wish we had more time for discussion because we could carry this on, I think, for much longer, really talking about the impact. I think we wanted to bring this here because we are talking about creating a rare disease drug strategy. We've got that opportunity. And certainly on behalf of all of the rare disease community, it is our goal to creating this program, not just to have something that's a little bit better, not just to say, geez, how can we do HTA a little bit better, not how we fund a little bit better, how can we have these products a little bit more, but we need to look at these kinds of products as well. And certainly we know that in the broad sweep of things, products that prevent symptoms, that can prevent, disease progression, that can reduce risk, oftentimes do not get favorable reviews. And you saw it already with Dr. Preventive presented, with what David talked about in terms of the previous, submissions through CADIS. And heaven help us if they refused it, the first time around. Goodness only knows what they're going to do the second time around when we're talking about a patient population that they would probably see as not nearly as urgent as those with inhibitors. And yet, as you say, at the end of the day, having huge benefits both to the patients and certainly to the rest of the system. We also thought it was really timely to bring this because these are the kinds of therapies that can keep people out of hospital. And I didn't know, Uzma didn't mention it, but I know other patients with thalassemia have said, I don't want to go in for a transfusion, into a hospital. And Dr. Pavinsky, St. Mike's just had, a few cases of COVID there. People do not want to go into places that have COVID. People do not want to, have risk of exposures. But in some cases, the message obviously is very strong to patients new transfusions. Do not avoid getting transfusions, and to other patients as well. If you have urgent conditions and you need to be in hospital, do not be afraid to go to hospital. They're doing everything possible to keep it safe, but we can, appreciate you don't want unnecessary exposure, and you certainly don't want to, have the psychological impact. So we are at the top of the hour. We are going to, really want to thank all of you for being here, and not just for being here, but for the work that you do, certainly to Kevin and to Catherine and to David, really in terms of advancing what's happening here, certainly for people, Uzma, Leanne, and to Yulan for your continuing support as we're moving forward. We look forward to having you join us in 2 weeks when we will have the third in our series where we're going to talk about individualized needs in terms of rare disease drugs. And also in the next couple of weeks, again, I think you'll hear more from us in terms of our concerns around the Patent Medicines Priority Review Board, the guidelines, and how they're going to make these situations even more difficult. And my fear is that these therapies might not even come to Canada at all, even in terms of clinical trials, if in fact the companies were not able to feel that they were going to be able to get it successfully marketed. So this is a huge concern for all of us. So thanks to all of our panelists again. Thanks to all of you for participating. You will get a link in terms of the recording of the entire webinar. And if you have any other questions or comments, please really feel free to connect with us. Thank you so much for joining. We'll see you the next time around.
Thank you. Bye.
Thank you.
Bye. Thank you.
Bye.
Thank
Bye.
you. Bye.
Okay, somehow I